Hey everybody, we've got another heart today. This is number 1651 in our collection, and we'll start off by looking at some of the phenotypic highlights of this heart. Now, a lot of stuff going on just externally, but you can see that there's in fact ventricular assist device cannulas in place in the right atrium, as well as in what appears to be a DKS anastomosis here. So this is a heart that had hypoplastic left heart syndrome, and here is the small hypoplastic left ventricle. Here is the small hypoplastic left atrium. And then here is a small mitral valve that does have a small orifice. So there is mitral stenosis, and then it is aortic atresia. So we're looking at a heart with hypoplastic left heart syndrome that has mitral stenosis, aortic atresia, that underwent a Norwood with a BT shunt, and also underwent a Glenn anastomosis, which was then undone, and the child was taken back down to a BT shunt in order to support them with a ventricular assist device. But let's go ahead and look at all of the anatomy of this heart. And the heart would have sat roughly in the chest like this: anterior surface towards the screen, posterior surface towards the turntable, head or superior here, legs are inferior here, left over here, right over here. So let's start off as we usually do, which is trying to identify, at least externally, what appears to be the right atrial appendage. And here we have an appendage that appears to be triangular, broad-based, or pyramidal. Obviously, there's a lot of suture line here that has altered the external appearance of the atrium, which highlights why it's important to use the internal components in the pectinate muscles when we can, rather than the external features, as they can be altered by hemodynamic change or by surgical intervention. So why don't we go ahead and open the heart here. And when we do that, we do find pectinate muscles that spill outside the confines of the appendage, consistent with the morphologic right atrium. We see that there in fact is a cannula that is placed into the right atrium, presumably for ventricular assist device support. There is a large oval fossa atrial septal defect, not surprisingly, a requirement to support the functionally univentricular multidistributive circulation this heart would have been a part of. And then here is the tendon of Todaro, and here is the mouth of the coronary sinus. And the tendon of Todaro, the mouth of the coronary sinus, and then the septal leaflet of the tricuspid valve form the triangle of Koch, which is here. And it is at the apex of this triangle that we expect to find the atrioventricular node. So here's the triangle of Koch, and we would expect that the AV node in this heart would sit roughly here. Now we do see that the superior caval vein is in fact still attached to this heart. We see that it is coursing down and empties into the roof of the right atrium here. There are suture lines anastomosing the superior caval vein to the right atrium, so it does appear that this child had underwent the Glenn anastomosis, which was then taken down to take this child back down to a stage 1 to support him or her on the ventricular assist device. When we look at the right-sided atrioventricular junction, it is guarded by a valve with 3 leaflets, 1, 2, and 3. Here is the septal leaflet, and you can see that this septal leaflet has direct connections to the ventricular septum here and here, consistent with a morphologic tricuspid valve. This ventricle here has coarse trabeculations, and there is, in fact, a septomarginal trabeculation. In the past, I've often made the statement, aka the moderator band, which is inaccurate. The moderator band is just the proximal portion of the septomarginal trabeculation, so I've tried to make it a habit to stop saying that. But here's the septomarginal trabeculation with its cranial and caudal limbs here, and we can see that the ventricular septum is in fact intact. As we come up into this pulmonary outflow tract, we do find that there is a ventricular arterial valve here, an arterial valve with 3 leaflets, 1, 2, 3, and with 3 sinuses, 1, 2, 3, all consistent with a pulmonary valve. And you can see that, in fact, this whole valve is supported by muscle. Entire muscular support is normal for the pulmonary valve. But in this case, we do see that this valve is leading to a pulmonary trunk, which is then anastomosed to the transverse and the descending aorta, consistent with a DKS anastomosis in the setting of a Norwood operation. So this, in fact, is part of the neo-aortic valve. So now this is the native pulmonary valve, now the neo-aortic valve. So then here is the pulmonary trunk, which is now serving as the ascending portion of the DKS. Here's the transverse arch here, and then here's the descending aorta here that has been anastomosed in this fashion. Here are the head and neck vessels, and we do find that the source of pulmonary blood flow used in this child is a BT shunt. So here is the BT shunt arising from the DKS anastomosis, and then these are the left and the right pulmonary arteries. Now we'll go to the posterior aspect of this heart here. And it's going to be a little difficult to open things up here, but we will try our best. Here is a second atrium that really doesn't have much of a vestibular component. It's really just a large atrial septal defect here. And so there is, in fact, a small left atrium with a large atrial septal defect. And then when we look at the left-sided atrioventricular junction, here is, in fact, the mitral valve. So the mitral valve is quite small. Once again, to kind of give you a sense of things, to remind you, here is the tricuspid valve, and here's a septal leaflet of the tricuspid valve, so fairly nice size. And then we get back here, and here, in fact, is this small mitral valve here. There is an opening, however, so this is mitral stenosis. And then here is the small LV cavity. So here's the left ventricular cavity here, quite hypoplastic. There is no aortic valve. So this is a heart with hypoplastic left heart syndrome, mitral stenosis, and aortic atresia that has undergone a Norwood with a BT shunt, then presumably underwent a Glenn anastomosis, which was then taken down to go back to a stage 1 to support this child on a ventricular assist device using this RA cannula and this cannula into the DKS. So an interesting heart with hypoplastic left heart syndrome, mitral stenosis, aortic atresia.